Welcome to the Academy of General Dentistry podcast series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started.
Hey, welcome back, everyone. We have another great show for you today as we welcome Dr. John Chao to the program, and we spend some time talking about gum recession and minimally invasive ways to deal with this problem. But before we introduce our guest, make sure you subscribe to our channel, hit the like button, and ring that bell. That way you'll be among the first to be notified of all things AGD. Dr. Chao, welcome to the program.
Thank you, George. It's a pleasure to be with you today.
Yeah, we're looking forward to some great conversation. I'm really glad you could spend some time with us here. Before we begin, let me just read a little bit about you to the audience here. We'll read your bio. So Dr. John Chao graduated from the USC School of Dentistry in 1967 and has practiced general dentistry in Monterey Park and Alhambra, California by Los Angeles since 1968. He received professional degrees from both USC School of Dentistry and Southwestern University School of Law. Dr. Chao teaches ethics at the USC School of Dentistry and holds the following professional titles: Master of the Academy of General Dentistry, Fellow for the Institute for Advanced Laser Dentistry, and a member of the Academy of Microscope Enhanced Dentistry. He is also an assistant research professor at postgraduate periodontics program at Buffalo School of Dental Medicine, SUNY, and an associate adjunct professor at USC. In 2012, Chao was recognized by the Herman Ostrel School of Dentistry of USC as a Teacher of the Year for outstanding service under the Division of Dental Public Health and Pediatric Dentistry. And he is the inventor and founder of the Pinhole Technique, and that's what we're going to talk about today. So I'm really excited to learn a little bit more about this Pinhole Technique, Dr. Chao. And of course, you're going to also be with us in Montreal for AGD 2025, July 9th through 12th. And looking forward to seeing you up there and looking forward to learning even more about this. But let me ask you, as we start here, what led you to come up with the Pinhole Technique?
Well, I was always be interested in how in dentistry, we can regenerate tissue when apparently there was none before. And I looked upon gingival recession as something, that I see all the time. And I was fascinated with the different ways that we can regenerate tissue around the teeth. We can regenerate gingival tissue. So I took many courses on that and ran into some wonderful clinicians, which was Dennis Shanilak, a wonderful periodontist, and he became my mentor and taught me how to do plastic surgery under the microscope. And that taught me all the minimally invasive techniques. And I realized that for any technique to be successful, the least amount of disturbance, the least amount of invasiveness you can generate, the better the results. So as I tried to learn the different ways to graft, I found out I was not very good at that. And I could do general dentistry. I love to do gold work. I like things precision, but when it comes to soft tissue, I just didn't have it in the hands. And Dr. Shanley tried to teach me, even tried to taught me how to cut the cell into half under the face microscope, and it was wonderful fun. But I realized that I'm not made for that, but I wanted to find a way to treat such a prevalent problem in my own practice. So it dawned on me one day that the course that I took at UCLA some years ago on how to do retrograde surgery, it came into my mind because that course was called Through and Through endodontic treatment. In other words, you open up to the tip of the root, and then you just go ahead and perform your instrumentation. You overpack it, and then you cut off the tip, and then you clean it up and sew it up, and that's it. So I did a lot of those, and I realized one thing that really impressed me, that after that surgery, hardly anybody ever complains of pain. You make the incisions, you break a hole in the bone, and you fill it up, you suture it, no problem. So that stuck in my mind, and I was now struggling with this idea of how to bring the gum line down to where you want it. I realized that maybe, just maybe from the apical end, from the mucosal apical end, I can make entry and be able to bring make that a successful operation. And I started doing that, and I realized that number one, postoperatively, there was just no problem at all. And I realized that once you, if you make a long incision, you have to suture it back up, you kind of detract from the results because it gets pulled back again. So as I make the incision smaller and smaller to where it becomes a pinhole, I could get a lot of tissue to come down to where it needs to go or up from the lowers. And I realized that once that comes down, it's a matter of basically stabilizing it with some kind of a material, and ended up using some resorbable membrane. So that was what started it. And I realized that with the pinhole, with such a small incision, instruments that we have available, such as all bands, is not going to do it. So then I, on a journey of 5 years, to develop instrumentation for this technique that goes through the pinhole and be able to release tissue underneath. So once the instruments are out, I begin to do document my cases, and eventually I publish in the International Journal of Periodontics and Restorative Dentistry, and then begin to show other doctors how to do this. And now we've trained about 4,000 dentists in North America and all around the world how to do pinhole.
That's incredible, because there's such as you said, there's such a need. I mean, I know when I had in my practice in New Jersey, when I was in New Jersey, we had so many folks that could benefit from this, and a lot of people are averse to going for periodontal surgery, right? They hear the word surgery and they don't want to hear that, and they don't want to go for that. But what you're describing to me is a way that we can eliminate a lot of that perception, maybe, by recharacterizing what's happening when getting the same result. So let me ask you this. Let's walk through this little by little. You mentioned a lot of things there, and I want to go back and I want to cover that.
Okay.
So when you talk about the pinhole technique, let's talk about the case. So you have a case of classic recession, let's say. How much, how much recession can we reasonably expect to treat with the pinhole technique and get success?
That's a great question, and it's a good news. Basically, I want you to imagine you have a curtain, and you want the curtain to drop down because it's too far from the floor. You could cut off a piece of it from somewhere else out of the curtain and attach it down to where you need it, which is the grafting technique. And now with pinhole, basically we release the whole curtain and let it drop from the top. And so there's no cutting, there's no stitching, there's no patching. The whole thing comes down and covers everything. In fact, when I finish doing pinhole, the gum line is very much close to the contact point. We overcorrect because there's so much tissue there. So I don't worry whether the recession is 3 millimeters, 5 millimeters, or 7 millimeters. It's the same procedure to correct the problem. So basically let it down and that's it.
So you're just going to release that tissue. So a couple of questions there. So when you do that procedure, number one, any concern about the vestibule, and if you're going to release that and drop it down in terms of the vestibule and the pressure that might be applied there to sort of want to pull that tissue back up or down, for that matter, in the mandible? What are our concerns there?
Yeah, anatomically, it's this technique fits in really well with the mucogingival tissue there, because it is vestibular tissue. So there's a lot of it. We just have plenty of tissue that we can bring down, and then if we can stabilize it some way, there's not the pulling that you would imagine that would happen. Now, you can go ahead and stretch it and so on and be able to pull on it, but generally there's so much tissue there. There's just there's not a problem. And basically, we don't try to when we do pinhole, we don't try to split the flap. We go right down to the bone. We peel the entire soft tissue flap away from the bone with the periosteum. So, and there's hardly any blood vessels or nerve tissue or innervations that comes from the bone to the soft tissue on the upper, because on the lowest you have the mental foramen which we can talk about. But there's no anatomical features below the vestibule that we need to worry about on the uppers. We have the frenum, which we can easily release. And so the only anatomical feature that we had to be concerned about will be the metal foramen, which we can talk about.
Yeah, we can talk about that in a few minutes. So in the maxilla, then you're going ahead and releasing that, and that was going to be one of my questions. So you're not trying to create a split thickness flap. You're basically you're going right down to periosteum. You want to release everything when you go in there. And
Absolutely.
and how many teeth at one time can you do the entire arch? Is it quadrant? Do you do sections at a time? Obviously, you're going to treat only what's needed. But let's say that patient had a significant amount of recession. How much can we reasonably attempt to treat at one time?
That's a great question, George. What we can do is it is a peculiar characteristic and advantage of pinhole over any other method in the fact that we can do the whole arch in a very short time because we're not suturing. We don't have to spend the time to try to split the flap. We're going right down to the bone. We just release the tissue with the periosteum from the tissue. So it is a procedure that could be easily done full arch all at the same time, if it's needed, of course, and have it done very, very commonly in about an hour to an hour and a half, if you have any level of experience at all. In fact, I routinely do a full arch in the one-day course I have in the morning and one full arch in the afternoon on the lower. And it's about an hour and a half with me talking. So it is a very, very, very efficient way to treat multiple sites of recession, and without requiring the patient to come back repeatedly for grafting procedures. So it is a great advantage in terms of not only that it is fast, but you don't have to spend any time suturing, which is according to my experience and most experiences, the experience of most periodontists and surgeons, that they spend about half the time suturing. The rest of the time they do their surgery. So with pinhole, you save half the time.
Absolutely.
You can do an upper and lower arch the same appointment, which happens quite a lot in my practice. And
so
doctors are encouraged to do that.
Yeah. So as you describe the technique, of course, it's the pinhole technique. So we know that there's a very small incision made near the area that you want to reflect. You've described that you're going to go in with an instrument. We'll talk about instruments in a little bit. You're going to go with the instrument. You're going to go in and release the periosteum in any area that it needs treatment. No sutures. How are you going to stabilize that tissue? Of course, on the maxilla, we have gravity, but on the mandible, how are you going to stabilize that release so that you get the coverage and it stays there?
Well, now imagine that the tissue is all loose.
Mm-hmm.
The mucosal tissue is attached to the bone. We have released it from the bone. It's all very, very lax. So how is it going to stay down there? And what I've discovered is with the pinhole, which is made with a 16 gauge needle, we no longer cut it with a scalpel. We just put your hole, and through that hole, I can feed strips of resorbable collagen. And the collagen strips can be fed through the hole, which you can slightly enlarge. You'll go back, and then we feed the collagen to go under the flap. Mostly, it's under the papilla. And then once you stabilize the papilla, then the flap will basically stabilize to the position that you had it. One thing I want to bring out, the difference also between pinhole and most other techniques is that in pinhole, we actually elevate the papilla. We don't cut it, we don't do anything with it, we basically release it. So it's down to the contact point, bulges out, and then we just basically stuff collagen like we stuff a pillow. And then you put enough in it, it stabilizes, and then it just then let the patient go and let it heal.
Yeah, that's fantastic. So when you're going in and you're coming in, you're going through the pinhole and you're going to release that periosteum, or do you going all the way down into the sulcus, or you're going through the sulcus, or you're approximating the sulcus, or you're just going to release everything with your instrument right through? How's that look?
Good question. Total release. In other words, I can stick my instrument through the sulcus. You can see it at the gum line. You're asking a wonderful question. You understand the procedure. So everything is down. There's nothing holding, nothing attached to, there's nothing attached to the flap. You're totally loose. The only connection is to the bone on the lingual.
Okay.
And everything else is loose completely. And
Okay.
so because we're not, what's really nice is because we're not cutting any blood supply off, we're not cutting any, even close to any innervation of nerves. It's a very minimally, in terms of symptoms, morbidity is very, very low. Very
Yeah,
low.
it sounds absolutely like it would be that way. And then, of course, you said you're going to put collagen in there, and you feed your collagen in strips. Do you have to make a secondary incision to slide it to pull it, or are you able to manipulate everything through your small pinhole that you put in there, your collagen pieces or whatever your choice of graft is?
Through the pinhole. We can make the pinhole a little bit bigger by stretching it. And then we
Okay.
can feed it in. We don't have to make any secondary incisions. It's just basically pinhole. On the uppers, we maybe do 4 or 5 pinholes. On the lower, maybe 4. And that's
Okay.
it. And those pinholes, after a day or two, you can hardly find them. Sometimes I cannot find them while I'm doing surgery. I have to look for the bleeding point. So it really is very conservative. It's made for the general dentist.
Wow. And so no sutures, not even the pinhole. You're not even going to suture the pinhole. You're going to
Yeah,
maybe a time.
the pinhole just closes. Next day, you can hardly see it. There's no
Unbelievable.
evidence of surgery except, of course, it's swollen, it's fat, it's red. But, you know, if you casually look at it, the gum line is here. By the time we got through, is down here. The teeth look like baby teeth.
Wow. And you do you over bulk the site and then expect some sort of recession back, or
Yes,
you want to overbuild it, right?
yeah, or definitely we would definitely over bulk it. We like it bulky. And the gum line is not, the flap is not resting at the CEJ. The flap is resting closer to the contact point.
Okay.
And everything is bulked up. So the patient feels the gums are swollen. Actually,
Right.
it's not because of swelling or edema from the gums. It just is bulked up by the collagen.
That's
So
fascinating.
they feel that it's really, really fat. And our main problem is getting the patients not to touch it.
Yeah.
Don't look
Yeah.
at it, don't brush it, and leave it alone and let it heal.
Yeah.
That's our big challenge, the patient compliance and observance. Because we tell them we tell them to brush your teeth every day, right? 3 times a day, and twice a day, and then all of a sudden you tell them not to brush. So that we have to kind of really train the patients to be careful with that. But outside of
Yeah.
that, we just sit around and wait for a wonderful result. It will shrink, to answer your question. It will shrink, but the gums will shrink generally onto some point on the root, depending on the proximal bone and the biology of the area. That'll give us the final result.
Fantastic. Dr. Chow, we're going to take a quick break for a word from our sponsor, and we'll be right back.
Okay. Good.
This AGD podcast series is sponsored by DHP, one of the largest family-owned full-service dental dealers in the U.S. DHP provides dental and medical supplies, equipment repair, maintenance, technology, and equipment sales to clinics and practices nationwide. AGD members receive exclusive discounts and promotional offers when they buy from DHP. We are especially grateful for DHP's continued support of AGD. Their partnership helps make this podcast and the vital conversations we share possible. Discover why like-minded general dentists work with DHP by visiting their website at www.dhpsupply.com.
Hey, welcome back, everyone. We're with Dr. John Chao as we talk about the pinhole technique. Dr. Chao, I want to pick up where we left off because we were talking a little bit about, tissue manipulation and bulking up the tissue and grafting and so on and so forth. Let me ask you this. We talked some about the maxilla, but specifically on the mandible, because we have gravity. I know how we described we're going to plump up the tissue, pull it up to the contact area there, put in some collagen. Do you do anything special for the mandible to hold that tissue in place, or we basically treat both arches the same?
We basically treat both arches the same. The anatomy, because is a little bit different. The anatomy is such that the tissue between the cuspids on the lower teeth are tighter and thinner, and the contour of the bone is generally more is generally not as smooth. So a lot of porosities and the bone spurs and so on. So we do have to traverse that terrain with a little bit more care. So the tissue so generally it's more challenging for the new dentist and the new surgeon to kind of get used to that. But that with the right instruments, with the right sharpness of instruments, we can negotiate that. So between the cuspids, it's a little bit technique sensitive, and because the tissue is a little more fragile. But the main problem, which Pinhole can basically address, and that is we can do the pinhole surgical technique and don't even have to worry about the mental foramen. We don't worry about the mental nerve.
So that was going to be my question, because a lot of folks are going to envision this and they're going to say, okay, I'm going to go in there and I'm going to go through the pinhole and I'm going to elevate this down to the periosteum, but then I have the mental foramen to worry about, and they're going to be concerned about that. So talk to us a little bit how we can navigate that. And of course, a lot of training needs to be done here. There's a learning curve. We'll talk about how the folks can get that when we're done. But conceptually, how are we going to navigate around that mental frame and not cause a problem?
Okay. The tissue on the lowers are much thinner than the uppers. And so we don't have to go apical to the mucogingival junction. So you have the movable tissue and you have attached tissue. The mucogingival junction is right there. If we can elevate the mucogingival junction tissue, elevate it coronally, then the rest of the tissue, which is very, very thin, you will just follow. So basically, the mental foramen is here. So we put the pinhole right over the cuspid, which is not even near the mental foramen, or sometimes even more mesially. And then our instruments, basically, it's pointed upward from the pinhole going this way. And so we never go below or apical to the mucogingival junction, which is way, 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 way higher than the mental foramen. So we basically elevate it this way. And then we don't go down, so we don't worry about any injury to the mental foramen. There's just not a problem with the pinhole. All the other surgeries, they required a apical dissection, which then calls into mind, how can you avoid injury to the nerve? So we don't have a mental foramen problem at all.
What about some other complications we might face in a procedure like this? Do you ever have any issues with bleeding or any of these kind of issues?
The bleeding, there's always generally bleeding afterwards. So we do have to tell the patient, expect some edema is part of the healing process. We'll tell them not to be alarmed with it. In terms of complications, the only thing that you might run into is some kind of an infection that starts 2 or 3 days afterwards. And generally it could be the patient's oral microbiome that could be high in bacterial content. So since we've been instituted a DNA bacteriological test for prospective patients, and then we're able to see whether we have a patient with high bacterial count of certain pathogens. And those will do, then we do put them on prophylactic antibiotics, or if they have any kind of high count with pockets which are borderline or deeper than that, we do treat them for perio and then clean it up before we do the surgery. So with proper antibiotic prophylactically prescribed, we just don't have any postoperative problems. We don't have any pain, let's say on 0 to 10, with pain beyond 1 or 2 or 3, the most. And most patients take about 3 or 4 Advils with Tylenol the first couple of days, and that's it. Yeah. Pain-wise is not a problem. Swelling, some people swell more, they bruise and so on. That's something that we have to contend with.
Patient by patient.
Postoperatively now, I do have to tell you, it is possible and that it is possible that you can break a papilla. And there's ways to actually take care of that and not have the patient end up with a black dark triangle. So those are complications that can be easily avoided with good techniques.
Yeah, I love the idea that you're testing your patients because I was going to ask you, your protocol for pre-op, and we'll talk about a little bit more about post-op in a minute, but for pre-op and whether you pre-medicate the patients, but you're testing the patients for
Yeah.
wow, that's fantastic.
Would you give me a test? Yeah. So we tested, and since I've been doing that the last 5 years, I don't remember the last time we had a uh, post-surgical infection case where I prescribed any kind of pain medicine. I just
Wow.
don't recall ever prescribing anything uh, post-surgically for pain except take a combination of Tylenol with Advil. That's it.
Wow. So, Dr. Chow, for the folks that are listening, just by audio only, you held up a little placard. Can you explain what you're holding up there?
Yeah, this is a report that came back to me on one patient describing the level of the different pathogens. And of course, this is normal, this is high, this is beyond high. So, and this patient tested for all 11 pathogens, he's be beyond high. So
Wow.
one of these, so some of the samples are Porphyromonas gingivalis, Forsythus, Fusobacterium. So some of the pathogens which are associated with periodontal disease are tested for. And then depending on what comes back, we do take steps to control it and then maintain it at a lower level. If it's the kind that tend to recur. On this spectrum is not so problematic, but on this section it is. So depends on what comes back, then I can address the bacterial problem, which I really believe is part of the causative factor.
Yeah,
That
it's
why
great.
do people with good hygiene, hardly any pockets, end up with losing bone on the buccal of the teeth? And you can say ortho is partly responsible, but bacteria, you can say overbrushing, you can say bruxism, but bruxism in the absence of inflammation doesn't cause bone loss. In the presence of inflammation, then you have a problem. So we do get into treating bruxism, and to take that out as a factor in the long-term results that we're looking for.
Yeah. So it looks like you're obviously taking great care to make sure that you have the ideal environment and giving yourself the opportunity for the greatest success by not only testing for, bacterial pathogens, but making sure the occlusion is good. I'm sure phase one therapy and scaling and root planing and all these kind of things are done. Let me ask you this, and I don't want to talk specifically about fees because we don't want to get in any kind of trouble here, but when you are doing all these types of this case, is it all one fee? Are you charging, in other words, are you charging for your perio testing and so on and so forth? Or is it basically this is the fee for the quadrant of pinhole technique? How are you doing that? And what codes are you using?
Yeah, I basically go by what codes are available, and 4270 is the code for pedicle graft,
Okay.
and then we use that most commonly when we claim pinhole. Pedicle graft, in case somebody doesn't know, you move tissue from one tooth to the next one, and the way it's defined is moving tissue from the adjacent locations. It could be apical, could be mesial distal. So if you use that code, it fits pinhole perfectly. So we claim tooth by tooth. We
Okay.
don't do quadrants and so on. So we look at each tooth.
Okay.
What recession is there? Is it class 1, class 2, class 3? What classification? And what is the nature of that recession? So we have a record of every single tooth that we're treating. Okay, a separate diagnosis for each tooth. Like you do a crown, you have a diagnosis of
Okay.
crown or filling and so on. So, and we don't have we certainly have a fee for orthotic appliances if we do that, and the treat bruxism. So we do take appropriate CT scans to diagnose bruxism and the loss of bone and so on. So we have a whole set of pre-surgical protocol that we get through, and that's what's enabled me to be able to publish 14.5 year study recently
Yeah.
here, based on the first study. So
I saw that you had more than a 14-year study with proven results there. Are you charging also separately for any grafting alloderm or something like that they might use? Or when you just charge that pedicle graft, that's your only fee? Or do you charge the graft as well?
I don't charge graft if I claim 4270.
Okay.
It's so complicated.
Yeah.
Sometimes if you charge for a graft, they will only allow one tooth, allowance for one tooth per quarter. So it gets very complicated. So I keep it simple, and then I just charge per tooth, and whatever they cover, they cover. And if we do a full arch, you're gonna use up the maximum
Oh,
anyway.
sure. And are you putting each patient in a night guard to stabilize the occlusion for the healing as well?
If I could show, if I suspect bruxism, which I would have to say is about over 90% of the time,
Yeah.
there's a bruxism factor there. There's a wearing down factor, and I explain to the patients, and they seem to accept it well. That is, I say when you chew with food between the teeth, you're generating about 30-40 pounds per square inch, like your car tire. But studies have shown when you clench tooth against tooth, you're generating 200 pounds or more per square inch. So that puts a lot of pressure on your teeth. They can wear your teeth down. They can cause your teeth to break down so that you may need to have crowns done. But you certainly can exacerbate a recession problem because you're causing more bone loss, more inflammation, and so for long-term results, we need to look at the bruxism problem and treat it in the appropriate manner.
No question about it. So what's the healing time for a case like this? When,
Um,
actually, if you could describe the stages of healing and then when can we expect them to be healed?
Okay. Um, when you look at it immediately after surgery, you see puffiness, you see red tissue, but the tissue is at the right place. In about a week, when the redness goes away, you basically have thick tissue. You can't even tell if you're a dentist because you can tell, but if you're a layman, if you're a patient, you're basically done. There's no sign of surgery because there's no stitching, there's no incisions, there's hardly any pain, and so by the third day there's no pain, and so in a week the whole thing is healed up.
Wow.
There's no problem with healing at all. And that's one of our disadvantages because when they don't feel any pain, when there's no soreness, they begin to brush it.
That's right.
That's what we have to fight the most. So we
That's
do see the patient in a week. We see the patient the next day. In a week, we check the patient. Then we re-educate the patient. We say, look, remember now, don't brush, don't lick it, don't tear at it, don't look at it 20 times a day, and put your finger on it. So that's our biggest challenge in terms of anything we do post-surgery.
And are you putting them on Paradex and things like that at post-surgical?
I give them a warm mouthwash. I'll give them a Peridex or something like that. But basically, it's something they use one bottle of. That's it. I don't think it makes a whole lot of difference what they use, as long as they as long as they brush the rest of their teeth. They can brush the lingual, they can brush the occlusal, but just don't brush the wound, and then
Right.
I'll be okay. So mouthwash is not a big issue with me.
Yeah. Well,
If you really want to, you can put a little salt in it and gargle with some salt, but don't do this. Just
yeah.
let it slide. So we do have to go through that because there's no stitching. Nothing's attached by sutures. So we have a different different set of problems that we have to deal with, which is much easier than having to deal with pain and sutures and bleeding and so on.
Yeah. So, we're running short on time, but there's a couple other quick things I want to touch on. And of course, you need the training. And I know you give some excellent and fantastic courses out in California. And I'm going to ask you to share how people can learn more about that in a few minutes. But I also know that you need specific instruments to try to do this kind of procedure. So we've talked a little bit about this, and I would caution people to be hesitant to try to go back to their office and find an instrument and try to do this, right? You've got to have specific instruments to navigate what you're talking about.
Yeah, it's something like this. This goes into the pinhole,
Mhm.
and blade here allows us to detach the tissue away from the bone. It allows us to go through it and elevate the flap with the periosteum. And so how you use that, there's just no instrument that's devised for this purpose. So
Yeah.
you can try to use other instruments, but it becomes a real problem. And you have to be able to get between the teeth. You have to get the papilla elevated. So just elevating it down to the gum line doesn't do that much good. So
Yeah.
it's a whole system. You can even have the instruments, but if you're not shown and taught how to use it, and then that can create problems too. So
Of
it's one
course.
system, and it's not that hard that hard to learn. We have an online course. A doctor can be trained to do this after the online course.
Oh,
With me available to do consulting and backup, of course.
sure. See,
And
I didn't even know about the online course, but for those that couldn't see, because we have a lot of audio, we have a lot of listeners that don't follow the video. It was just basically an instrument that looks like a curette, a long curette with multiple bends on it.
Yeah.
Nothing that I could describe. Yeah, several bends on it. So listen, Dr. Chow, fascinating. Love the concept. I think it's really great service to the patients for it's minimally invasive. It sounds like a wonderful technique. And I know you do, like I said, you teach that in California. You've got your online version. If folks want to learn more about this or they want to get a hold of you, how can we do that?
just type in Pinhole Academy, and then you'll be able to find our main website and our phone numbers and the contact information. Or just type in John Chao, DDS, and then you'll be able to find me. I'm not hard to find. I'm all over YouTube.
Wonderful. And I'm really looking forward to seeing you up in Montreal. That's Montreal AGD 2025, July 9th through 12th. I'm looking forward to stopping in and hearing you speak and learning a little bit more about this. Thanks so much for coming on the program.
Thank you for having me. I really enjoyed it. Thank you so much.
Yes, you're welcome. I'd also like to thank our producer, Kristen Govern. If you like what you heard, please like and subscribe to our channel. You can always find us on the AGD app, Spotify, SoundCloud, Apple Podcasts, and on YouTube under @General Dentistry. If you have any questions, concerns, comments, or suggestions, contact us at news@agd.org. Thanks again, and we'll see you next time.